GLP-1 drugs have become increasingly popular, has drawn attention to this relatively new class of drugs.
So these drugs have existed for years. Then suddenly, in the past few years, the headlines were all about weight loss and celebrities were talked about it on the red carpet, influencers with their weight loss journey all over the place, and the hype became louder than the biology. That's when we need to pause a little bit. Hi, I'm Sina, a clinical pharmacist, and my fiance is living with type 1 diabetes. If you're type 1 and considering a GLP-1 agonist, ask yourself this. Why does the same drug work so differently in type 1 diabetes versus type 2? When should insulin actually be reduced, and when is that dangerous? Why can your CGM look just fine while your body is sliding towards DKA? What else do you lose when you say that I've lost 20% of my weight in a year? These are the things that we're going to try to break down today. So first, let's talk about what GLP-1 actually is. GLP-1 is released from the gut when you eat. I guess you probably knew that. It signals three main places: the pancreas, the stomach, and the brain. For the pancreas, it basically tells the pancreas to start secreting more insulin. It tells the stomach, slow down your gastric emptying. And it tells the brain, reduce your appetite. And the result is you get full, you stay full, and your post-meal glucose is often smoother. Now, native GLP-1's half-life is about 1 to 2 minutes, and fellows, no matter what you tell yourself, 2 minutes is not a very long time. Now, pay attention to this. These drugs are long-acting GLP-1 receptor agonists. They do not make your body produce more GLP-1. They do not protect or prolong your natural GLP-1. They directly bind to and activate the GLP-1 receptor. When I was a kid, sliding doors at supermarkets were just super fun. I remember this one time, I was wearing my favorite red jacket, and with my friends, we would try to figure out how the door knows when to open. And how does it know we're even there? And then we'll just stand there to see if we could keep it open forever. And I remember this particular time because I got scolded really bad with my mom and the store manager. Okay, now think of GLP-1 receptors like these automatic sliding doors in a supermarket. One leads to the pancreas, one to the stomach, and one to the brain. Normally, when food comes in, the motion sensors trigger briefly and the doors open. They do their job and then quickly close. For GLP-1 drugs, well, they don't build new doors. They don't upgrade the sensors. They're more like these kids standing there holding the sensors down. As long as the kids are there, all the doors that can open. The moment the kids step away, the signal drops and the doors close and everything goes back towards the baseline. In type 1 diabetes, the motion sensors work everywhere. The signal is sent. The stomach door opens. The brain door opens. But the pancreatic door, that one has no motor. The beta cells are gone. And I guess, again, you already knew that. The door simply cannot open, no matter how strong the signal may be. In type 2 diabetes, all the doors and motors are still there, but the motion sensor is weak and quite inconsistent. Sometimes the doors open late. Sometimes they barely open at all. And that impaired incretin signaling, both secretion and response, is what we call the incretin defects. Now, this is important to understand. Type 1 is primarily a response limitation at the pancreas. Type 2 is primarily a signaling and responsiveness problem. My fiancée typically asks a lot of questions about her topics of interest. It sometimes gets really annoying, but it's been a habit that I have also picked up. While I was sitting on my chair reading about this adjunct trial results that I will discuss with you a little bit, I asked myself, is there a relationship between the type of food we eat and amount of GLP-1 that is released? But let me ask you first. Think about it. Do you think your body produces different amounts of GLP-1 when it's exposed to high-fat food versus high-carb food? And what if you are type 1 or type 2 or non-diabetic? Would it be different? All right. So carbohydrates and proteins produce the strongest GLP-1 release in non-diabetics and people with type 1, mostly. Type 2 gets a much less GLP-1 response. But with dietary fat, that GLP-1 release tends to be more preserved across all the groups. Of course, magnitude varies. And this is one reason GLP-1 agonists help type 2 diabetics so well. They replace and amplify a weakened physiological signal. Now, what does this mean for treatment differences? Let's look at what the trials actually show for type 1. Now, first of all, GLP-1s are not FDA approved for type 1 diabetes. That means your insurance usually wouldn't cover them. There are not many large long-term clinical studies in type 1 diabetes, so long-term safety data are quite limited. But the Adjunct 1 and Adjunct 2 trials are the largest GLP-1 studies for type 1 diabetes. Now, over 2,000 people using liraglutide alongside capped insulin were studied. And now think of it back to the supermarket doors that we talked about earlier. At lower doses, the GLP-1 drugs gently hold the stomach and brain doors open. Now, people feel full sooner, eat less, and digestion slows, and insulin needs drop. Weight comes down, and post-meal spikes smooth out. At higher doses, especially early in the treatment, that stomach door can be held open too long. Food delivery is then delayed, and if you pre-bolus, insulin is already active. So insulin hits first, glucose drops, and then you get more hypos. Then the food finally arrives and there is delayed highs. In type 1s, especially those with gastroparesis, that timing mismatch increases GI side effects and can raise the risk of ketosis, which contributes to higher dropouts in some of the studies. Now, small semaglutide studies in type 1 diabetes have shown modest A1C reductions, true, but careful titration and monitoring are absolutely critical. These drugs are powerful, guys. Stay on them, and weight loss can approach even up to 20% in some individuals. But stop them, and a substantial portion of that weight might return. So no, they are not miracle drugs. They are tools, subscription tools. And tools need cost-benefit thinking. Now, here's the part that the social media doesn't discuss as often as I want them to. What you do on the drug matters as much as the drug. Hear me out. Rapid weight loss affects muscle and bone too. So low protein intake and no resistance training means there is greater lean mass loss. And lean mass loss with GLP-1s is a well-documented thing. Bone mineral density data are mixed, but rapid weight loss can increase risk in vulnerable individuals, especially those with low vitamin D, low calcium, and low baseline muscle mass. You could have even osteoporosis. Now, let's talk about type 1 diabetes and obesity. GLP-1s are typically prescribed for type 2 diabetes and obesity. But the association between obesity and type 1 diabetes is quite complex. About 62% of adults in the US with type 1 diabetes are overweight or obese, compared with the 64% of adults without diabetes and 86% of those with type 2 diabetes. So the idea that all type 1s are lean is wrong. Just like the idea that all type 2s are inherently obese. That's also wrong. So it varies from person to person. Historically, however, type 1 diabetics were thought to have lower obesity rates, but that assumption is just no longer valid. Yet, awareness and management of obesity in type 1 diabetes remains relatively low. So, do you reduce insulin on Ozempic or Mounjaro? Well, typically yes, especially meal insulin. And why? Because you're eating less, your food moves through the stomach slower, and your post-meal spikes are often less aggressive. But here's something that people might not fully understand. Insulin doesn't just lower glucose. It also tells your body, don't make ketones. GLP-1 drugs do nothing to suppress ketone production. So if someone cuts insulin too hard, too fast, especially basal insulin, the body thinks it's starving and then it starts burning fat. Ketones rise. And here's the dangerous part. Your glucose may look just fine. Your CGM looks okay, but you feel a little off. You check your ketones and then suddenly you see that your ketones are pretty high. That's your euglycemic DKA, basically DKA without screaming high sugars. You don't need to measure ketones every day, of course, but you should check them. At least when your appetite drops really hard, or when you're fasting, or you're barely eating or vomiting, or when you're sick and insulin doses change, especially basal. That's why insulin reductions should be slow, intentional, and monitoring driven, not just based on what you read on Reddit. So ketone strips are quite annoying. I know you have to already juggle a billion other things, but this matters. Remember, GLP-1 drugs don't cause DKA directly. They can set up the conditions where insulin underdosing plus low intake of food does. So, uncomfortable but important questions we should ask ourselves. If weight loss depends on staying on the drug, is affordability then a side effect? If weight returns after stopping, is that failure or normal physiology? Should dosing be more personalized? Should type 1s ever use GLP-1s off-label, with medical supervision, of course? Semaglutide reduces major cardiovascular events by up to 20% in high-risk type 2 and obesity patients. Now, why isn't that the headline? I want to ask you guys something. If you have used a GLP-1 agonist, what did your doctor say would happen in year 1, 2, and 3? Have you ever had to change your insulin dose? Did you see any changes in your ketones? Please drop them your experiences below. Let's talk about it together. And let's clarify certain things around this GLP-1 for type 1 diabetes and, of course, the lived experience. If you felt that you learned something new today, and if you felt that this channel could be the gap that we are trying to fill between healthcare professionals and lived experience, hit the subscribe button, and I'll see you next time.